Hello, and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shanmugam. What should be on our differential when evaluating a patient with diffuse lymphadenopathy and constitutional symptoms? While lupus, Sjogren's disease, and lymphoma should all be considered, Castleman's disease is a rare immune-mediated disease that sits at the intersection of autoimmune diseases and malignancy and should also be on our differential. It is named after Dr. Benjamin Castleman, a pathologist at Harvard University who first described it. Approximately 4,000 to 5,000 new cases are diagnosed each year in the United States. The manuscript we will discuss today is Diagnosis and Treatment of Castleman Disease. It was published in Arthritis and Rheumatology, and a link to the manuscript and disclosures can be found in our show notes from today. I'm so happy to be joined today by Drs. Luke Chen and David Feigenbaum to discuss this manuscript and their shared efforts to understand and raise awareness of Castleman's disease. Dr. Luke Chen completed his doctorate of medicine at the Dalhousie University. He completed an internal medicine residency at the University of Ottawa and hematology training at the University of British Columbia. He's currently a hematologist at Dalhousie University in Halifax, Nova Scotia, and he has a special interest in medical education, cytokine storm syndromes, IgG4-related disease, and Castleman's disease. Dr. David Feigenbaum is an accomplished physician scientist. Graduated from Georgetown University, where he was recruited to play college football. During his time in college, David's mother developed glioblastoma and died, and David founded a national support network for grieving college students. He went on to receive an MSc from the University of Oxford and later joined the MD program at the University of Pennsylvania. While in medical school, David himself became critically ill with idiopathic multicentric Castleman disease, and ultimately, after multiple relapses, he founded the Castleman Disease Collaborative Network, forming an international consortium of patients and scientists to accelerate discovery in this disease. David went on to finish his MD and complete an MBA, and he's now a physician scientist at the University of Pennsylvania, where he's one of the youngest faculty members to ever have received tenure at Penn Medicine. His memoir, Chasing My Cure, A Doctor's Race to Turn Hope into Action, is a bestseller and a great read, and I'm pleased to report it's also being adapted into a movie by Wendy Feineman, the Oscar-winning producer of Forrest Gump, and also The Devil Wears Prada. Dr. Feigenbaum now runs Every Cure, which has advanced more than 13 repurposed treatments for cancers and rare diseases. Dr. Feigenbaum's work is funded by the NIH, FDA, ARPA-H, and TED's Audacious Project. Welcome to the show, Luke and David.
Thank you, Vicky.
Thanks so much for having us. It's an honor to be here.
So Castleman disease is a mimicker that many rheumatologists and indeed many physicians from all specialties may never have seen in practice. You begin your manuscript with two cases. And Luke, to orient our listeners, could you tell us about these two cases?
Yes. So the first case is a 23-year-old white man who presented with fluid accumulation, anasarca, and thrombocytopenia, renal failure, and minor lymphadenopathy, so lymph nodes up to 1.2 centimeters. And then further investigations demonstrated bone marrow reticulin fibrosis. And so that's a classic presentation of the TAFRO subtype of Castleman disease. And then the second was a 42-year-old Chinese woman who presented with very chronic inflammation with an elevated C-reactive protein, chronically more than 50 milligrams per liter, somewhat larger lymph nodes of 2 to 3 centimeters, chronic anemia, elevated platelets of 450 to 500, and severe polyclonal hypergammaglobulinemia on serum protein electrophoresis with IgG of 65 grams per liter. And that's a very classic presentation at the other end of the spectrum of idiopathic plasmacytic lymphadenopathy. And both of these, the TAFRO and the idiopathic plasmacytic lymphadenopathy, are subtypes of idiopathic multicentric Castleman disease. And those are the subtypes of Castleman that I think are of most interest to rheumatologists.
And you have a nice flowchart in Figure 1. You are actually the first hematologist on our podcast, so I'm wondering if you can educate us a little bit more about the various types and take us through that flowchart.
Well, thank you. First, let me say it's an honor to be the first hematologist on the show. I worked in Vancouver for 15 years, and when I moved from the west coast of Canada to the east coast in Halifax, my colleagues in Vancouver gave me a plaque that says I'm an honorary British Columbia rheumatologist, and that has pride of place on my awards shelf. So it's really an honor to be the first hematologist on this podcast. In terms of the flow chart, I think one of the wonderful things that David and the Castleman Disease Collaborative Network have done over the past 10 years is really help us understand the full spectrum of ways in which Castleman disease can present. So we divided it along horizontally in terms of the distribution of lymphadenopathy. So on the left-hand side, there's unicentric Castleman disease, which presents in one lymph node region. And then on the right-hand side, there's multicentric, where you have lymph nodes in multiple areas on both sides of the diaphragm, typically. And then in the middle, there's a relatively new form called oligocentric Castleman disease, which was really only described in 2023 by David's group, where you have lymph nodes in more than one region, but on the same side of the diaphragm. And then on the vertical axis, we've divided it into patients who have systemic symptoms like fever and sweats and inflammation, and those who do not have systemic symptoms, so that their only symptom is the swollen lymph node. And so the asymptomatic is classic unicentric Castleman disease, and then oligocentric patients also don't have systemic symptoms. And then Dr. Lu Zhang, who's also our co-author, recently described a subtype of multicentric Castleman disease that is asymptomatic. And that's a relatively new discovery as well. It was traditionally thought that if you have multicentric Castleman disease, you have systemic symptoms, but there is certainly a subset that just have swollen lymph nodes and have no systemic symptoms. And then on the vertical axis, we also see that the spectrum of Castleman disease is more diverse than we originally thought, because traditionally it was thought that unicentric Castleman disease is just the swollen lymph node, and if it's bothersome, you just cut it out. But there are subtypes of unicentric Castleman disease that can present with systemic inflammation, with paraneoplastic pemphigus, with bronchiolitis obliterans, and sometimes with AA or reactive amyloidosis. And those patients would typically require systemic therapy. And then on the other side, on the multicentric side, there are many types of multicentric Castleman disease. There's POEMs associated, which is typically associated with a plasma cell neoplasm. There's HHV8 associated, which is typically associated with HIV or other immunosuppressed states. And then the subtype that I think is of most interest to rheumatologists is idiopathic multicentric Castleman disease. Idiopathic meaning it's not associated with HHV8, it's not associated with POEMs. And then there are three subtypes of that. There's TAFRO, which David has really brought to the forefront over the past 15 years or so. And then there's the NOS, which is traditional multicentric Castleman disease, large lymph nodes, inflammation. And then there's this subtype called idiopathic plasmacytic lymphadenopathy, which has been described mostly in literature from East Asia for over 20 years, but there was a lot of debate about where it belongs. Is it a subtype of IgG4 related disease? Is it a subtype of Castleman's? Is it its own entity? And really in the past few years, I think both in the Western Hemisphere and the Eastern Hemisphere, we've landed on the most sensible position that it is in fact a subtype of Castleman disease.
Yeah, and so you go into this further in Table 1, and I think this is the area where you're really keen to help raise awareness amongst the rheumatology community about these three subtypes. And as you mentioned, these are the groups that can mimic IgG4-related disease, Sjogren's disease, lupus, among other autoimmune diseases. Can you unpack that table for us, Luke?
Thank you. So table 1, I have some of the key features of the three subtypes of idiopathic multicentric Castleman disease. So there's NOS, which is a little bit of a funny name because that's kind of like, to me, that's the standard type of idiopathic multicentric Castleman disease. The patient with enlarged lymph nodes who's not typically that sick. It's someone who would typically show up to your office. And this is really the subtype that I think is best defined by the 2017 IMCD criteria that David and colleagues put together and published in Blood, where they have systemic inflammation, polyclonal hypergammaglobulinemia, anemia. They typically have relatively large lymph nodes, and it's typically relatively straightforward to get a good excisional or surgical biopsy because the patient's not that sick. And so you can see that they have the features of Castleman disease on the lymph node biopsy. So in my mind, this is the subtype that's most easy to diagnose because they're not that sick. They have relatively large lymph nodes, and often those lymph nodes are quite accessible. The idiopathic plasmacytic lymphadenopathy subtype, that's to me, the newest type, at least to us in the Western hemisphere. I think in Japan and China and Korea, for years, they've been diagnosing this and have had treatment algorithms, but it's a bit of a mystery disease in the West. In the past 2 months alone, I've had calls for advice from colleagues in different parts of Canada who call me about a patient with unexplained lymphadenopathy, severe anemia, severe inflammation, often Asian, but not always. And they've just been walking around as a medical mystery for years. And then when we get the pathology reviewed, we find that, oh, indeed, they have the plasmacytic variant of Castleman disease. They have this profound polyclonal hypergammaglobulinemia, often with an elevated IgG4 level, sometimes with some features of Sjogren's or LIP in the lungs, lymphocytic interstitial pneumonitis. And in fact, what their diagnosis is idiopathic plasmacytic lymphadenopathy subtype of Castleman disease. But for years, they were perhaps labeled as an atypical Sjogren's or a possible IgG4 related disease. And then finally, in the last column, we have the IMCD TAFRO subtype. So the thrombocytopenia, anasarca, fever, and reticular fibrosis, renal dysfunction, and organomegaly subtype of Castleman disease. These patients are probably the scariest to deal with because they come in very, very acutely ill and they have low platelets, unlike the other two subtypes. They often have very small lymph nodes, 1.5 centimeters. And often the surgeons are reluctant to do an excisional biopsy because they say, oh, well, the lymph node is so small, what's it going to show you? But in this context, when you have a severe cytokine storm, severe inflammation, and often normal immunoglobulins. So sometimes people don't think that perhaps it could be Castleman's. These patients are the most difficult to diagnose, but also the most critical to diagnose because honestly, the other two, NOS and IPL, if they sit as a medical mystery for a few months or even a few years, often the disease doesn't really progress. They're not well. It's not great. But TAFRO, if you don't diagnose it, often the patient goes into renal failure or the ICU or dies. So it's very critical to recognize that subtype early.
Oh, and I think that's so incredibly helpful for us as rheumatologists. I read that table and, I think probably everyone who looks at it will be like, oh, I should think of this disease more often. David, I want to bring you in now. In your book, you mention the moment of being handed your pathology report and realizing that your disease was so rare, you were going to need to find your own treatment pathway. There have been, though, a few more epidemiological studies since you were diagnosed. How common is Castleman's? Does it affect men and women equally? And tell us about these geographic differences in presentation.
Yeah, thanks so much, Vicky. And so appreciate all the important points that Luke has made. As you mentioned, I was diagnosed back 15 years ago. And back then, there was just less that was known about Castleman disease, certainly less known about idiopathic multicenter Castleman disease on a number of levels, from epidemiology, like you mentioned, all the way through how do we diagnose it, how do we treat it. So I'm thrilled and grateful for the progress we've made. On the epidemiological side, it's a very rare disease. Castleman disease, based on our best estimates, is diagnosed somewhere around 5,000 new patients a year in the US. Now, that's all forms of Castleman. So each of the subtypes that Luke just mentioned would fall into that 5,000 diagnosed each year in the US. And as we look across the world, we think that there's similar distributions of patients relative to population size all around the world. We hear about a lot more Castleman disease patients in Japan and China than maybe one would expect if it was evenly distributed. But we also realize that the scientific and medical communities in both China and particularly in Japan have a real affinity for Castleman disease. It's top of mind for a lot of doctors. It's something they think about. And so I don't know if it's that there's more cases there or if it's just that we learn about it a little bit more and we see more case reports. So fairly even distribution around the world. As Luke mentioned, some of these subtypes have been thought to be associated with certain regions of the world, like TAFRO and IPL. They were both described in Japan, but we see TAFRO and IPL patients in North America very often. In fact, over 50% of the IMCD patients in our registry, a US-based registry, are TAFRO, and about 25% are IPL, and the remaining patients we call NOS, meaning they don't fall into either of the other two categories. So we do see maybe there's some geographic associations with subtypes, but I think it's really just that some physicians in some parts of the world have done a better job describing these subtypes than others. These subtypes have always been everywhere, but they just hadn't really been characterized before.
Yeah, I'm sure that's true. And tell us, what do we know now about the pathophysiology of Castleman's?
Yeah, well, we've learned a lot. Probably the first major breakthrough in pathophysiology of Castleman's, particularly idiopathic multicenter Castleman disease, which I think is probably the most relevant for the rheumatology audience, because the other subtypes of Castleman disease, unicentric, we're going to just be easier diagnoses, and they really don't mimic rheumatologic conditions. HHV and associated MCD is an easier diagnosis to knock out, and similar for POEM syndrome. So I think IMCD, as Luke mentioned earlier, this is the one that's really at the intersection of autoimmunity. And so some of the big breakthroughs, I'd say the first one was back in the late 1980s, early 1990s, and that was when Kazuo Yoshizaki discovered that interleukin-6 was very elevated in a few patients with IMCD. And that observation inspired him to hypothesize that maybe blocking interleukin-6 signaling would be effective for the disease. He actually went on to develop the drug tocilizumab, which I suspect every single rheumatologist listening to this podcast has used tocilizumab for a variety of different conditions. Kazuo developed tocilizumab for Castleman disease in Japan. And actually, Luke will know this story well, but I had heard from one of our colleagues that Kazuo discovered IL-6 was important. He developed tocilizumab, and then I heard that Kazuo gave it to himself as the first human to prove that tocilizumab was safe. And when I asked Kazuo said, no, I didn't give it to myself. The nurse gave it to me. So, so he literally developed the target, developed the drug. He gave it to himself. And actually, when I chatted with him about it about a year ago, he said the reason he gave it to himself was because he was getting some pushback from the ethics committee on whether it was safe enough to give to patients. And so he said, I'm just going to give it to myself and prove it to you, which I think that's the kind of thing you could do back in the 90s. Now, I don't think I recommend doing that today. But, he was fine. And then he wanted to test it in Castleman's patients. It got approval in Japan for Castleman disease, but the company that made it was not interested in pursuing other Castlemans in other parts of the world. And so then it came to the US, and everyone on this podcast or listening to the podcast will know that it got approved for RA, and it's now used for a number of other autoimmune conditions and autoinflammatory conditions. So that was probably our first big breakthrough, is that IL-6 is important. That led to tocilizumab, which then eventually led to the development of siltuximab. Because toci didn't get approved in the US, there was a major need for an IL-6 blocker to be approved for Castleman's. And Janssen Pharmaceuticals is developing an IL-6 blocker called siltuximab for a few cancers, and they decided to include Castleman's along with those cancers. And it went on to get approval in 2014. It's the only FDA-approved drug for Castleman's, actually the only drug to ever undergo a randomized controlled trial for IMCD, and that's now standard of care. So IL-6 blockade is clearly effective for 1/3 to 1/2 of patients, which is just amazing. We're so fortunate with such a rare disease to have an approved drug that is effective for such a large portion of patients. But unfortunately, there's still 1/3 to 1/2 that don't respond to IL-6 blockade. And so for those patients, first, in my case, we discovered that mTOR, that signaling pathway, was very important. That led to the use of sirolimus for me and also for other patients. More recently, we discovered a role that JAK-STAT3 signaling is playing, which has also led us to use a JAK inhibitor. We're opening up a clinical trial later this year of the JAK inhibitor ruxolitinib in IMCD. We've also observed that there are patients that have autoantibodies with IMCD, and we hypothesize could potentially benefit from B-cell depletion therapy, and a small fraction of IMCD patients will get better with B-cell depleting therapies like rituximab. And then the rest of patients that don't respond to these therapies will get multi-agent cytotoxic chemotherapy. And the good news is that we don't like to give multi-agent chemotherapy to patients, but certainly in Luke's case, in my case, we're aware of a number of patients where multi-agent chemotherapy was necessary to get them out of crises. And then many of these patients, myself included, can go back to their lives.
Yeah, that's amazing. And thank you for sharing all of those insights into the history of development of these drugs and how they came to be used. Luke, I'm going to jump back to you now. Take us through your approach as a hematologist to diagnosing and managing Castleman's in practice. And maybe we could start with the scenario in case one of the manuscript, which is this young man presenting with thrombocytopenia, anasarca, fever, reticulum fibrosis, renal dysfunction, and organomegaly. How would you approach a case like that?
Well, that's such a great question. And it's something that I think we've learned so much about in the past few years. So to me, there are two classic scenarios where a physician should think about Castleman disease, which are the difficult scenarios. The easy scenario is when a well patient shows up with lymphadenopathy, because then you just keep working at it until you get enough tissue to diagnose what is it, lymphoma, Castleman's, et cetera. So that's pretty easy, not too much of a diagnostic challenge. What is a diagnostic challenge is two scenarios that we start with in the paper is one, the patient with severe cytokine storm who's very sick. So the whole concept of cytokine storm is really something that's, I think, caught on in general medicine in the past 5 years for people like me who studied hemophagocytic lymphohistiocytosis, or HLH. We thought a lot about cytokine storm, but because it was rare, it really wasn't in the consciousness of the general medical community. But then when CAR T cell therapy came along, and it turned out that IL-6 inhibition was very important to control CAR T cell cytokine release syndrome. And then shortly thereafter, a little virus called COVID-19 came along, and we discovered that COVID-19 cytokine storm was a big part of the reason that some people got very sick with it. Cytokine storm suddenly became a very important general concept in medicine. And then David, along with Dr. Carl June, wrote a very highly cited review on cytokine storm syndrome in New England Journal of Medicine in 2020. So suddenly this concept of cytokine storm is in the general consciousness. But still, as clinicians, as everyday clinicians, I think we need a practical approach to what to do with a patient with cytokine storm. If you go to a lecture about cytokine storm, including, a lecture given by me or David, I will say that there tends to be a lot of hand waving about cytokines and chemokines and that sort of thing, but they're not that easy to measure in clinical practice. So we need to look at phenotypes based on the patient's clinical presentation and standard lab tests that we have readily available to us. Things like the CBC and the C-reactive protein and the ferritin. And so the classic presentation of TAFRO is a younger male patient, traditionally often Asian, but anyone can get TAFRO. And of course, women can also get TAFRO, but there is a male predilection. And it does typically affect younger patients when they present very sick with severe inflammation of very high C-reactive protein, typically more than 100 or 200 milligrams per liter, or in American units, 10 to 20 milligrams per deciliter, with low platelets, with anasarca, with renal dysfunction, whether it's renal failure or profound proteinuria, so it's really important to check an albumin to creatinine ratio, then you should think about TAFRO. Whereas the patient without that much fluid accumulation, who may only have a modestly elevated C-reactive protein but a very high ferritin, then you should think more along the lines of an HLH type of presentation. So if you do have someone with a TAFRO-like presentation, it's important to look for lymphadenopathy, to do a CT scan from neck to pelvis to look for lymphadenopathy. And even if the lymph nodes aren't that big, it's important to consult ENT or general surgery to get an excisional lymph node biopsy. And getting as much lymph node as is safely possible in a timely fashion is crucial, because core needle biopsies are not enough for the pathologist to look at. The pathologist really needs a good chunk of lymph node to help you make the diagnosis. And often, if the lymph nodes are only 1.2, 1.3 centimeters, there's not that much to begin with. So we have to get an excisional lymph node biopsy. And I will also point out that very recently, David wrote an important paper in American Journal of Hematology with Japanese colleagues surveying the Japanese experience with TAFRO and with Castleman's. And out of 104 patients with TAFRO, 26, so exactly 25% of those patients in Japan with TAFRO actually had no lymphadenopathy at all. So I was a bit skeptical of this a few years ago, but there is such a thing as TAFRO without lymphadenopathy, or TAFRO without Castleman's disease. So whenever there is lymphadenopathy, we do try and make that histological diagnosis just to make sure we're not missing an intravascular lymphoma or an atypical infection or something else that might be mimicking TAFRO. But that's my approach to this very difficult scenario in a nutshell. And I'm sure David probably has some comments as well.
What about that patient with the atypical lymphadenopathy who's not acutely ill? How would you approach that patient?
So in general, my approach to a patient with atypical lymphadenopathy is to get as much clinical and laboratory data as possible to try and narrow down the differential diagnosis. So it's very important to get a good clinical history and exam. In typical IPL, although they have anemia and severe inflammation, they're often not particularly sick. They're kind of the walking wounded. They've been living that way for many years. And, they may feel very tired, but they're able to go on with things. And then get as many lab tests as possible that are relevant. The CBC, the serum protein electrophoresis. IPL typically has very profound polyclonal hypergammaglobulinemia. The Japanese use a cutoff of gamma globulins more than 35 grams per liter. The Chinese use a cutoff more than 17.5 grams per liter. But the fact is that they have elevated gamma globulins and a very high C-reactive protein. And then to try and get a CT or a PET scan to determine the extent of the lymphadenopathy, and also to rule out mimickers. If someone has extensive bony disease, that's not Castleman's. That's more like a histiocyte disorder or a lymphoma or another malignancy. Castleman's does not present with extensive bony lesions. And then to get a good biopsy, to get a good excisional biopsy and get it reviewed by a pathologist with expertise in rare diseases like Castleman's and histiocyte disorders. Often I do see these patients who have come in and they've had biopsies done years ago in a community hospital, and the report is no evidence of lymphoma or no evidence of malignancy. Because if you're a pathologist in a community hospital with high volume, your priority is to make sure the tissue in front of you is not a cancer. And then I often see that once that's done, they kind of wash their hands of it. Well, there's all sorts of reactive changes that they mention in the description, but once it's not a cancer, they sort of sign off on it and send it on its way. But what is it, right? So you need a pathologist with experience in these diseases to review it.
Well, so luckily, in figure 5 of your manuscript, you have some beautiful images of the key pathology to look for. And I would urge every rheumatologist listening to this podcast to look at those images and then take them to your pathology department and maybe do a journal club on this, because a picture is worth 1,000 words. Can you describe some of those for our listeners, Luke?
Sure. So I'll be honest, I often have to look up the pathological criteria for Castleman disease because I'm not a pathologist, but I will just say at the outset that one of the key things is clinical pathologic correlation. Often with these patients, it's not fair to ask the pathologist to make the diagnosis for you. The histological findings have to be interpreted in the context of the clinical picture. So it's so crucial for clinicians and pathologists to talk to each other. Because, as an example, there are 5 types of IgG4-related lymphadenopathy, meaning 5 types of lymph node abnormalities that can occur in IgG4-related disease. And one of those subtypes is Castleman-like. So if you have a patient with a swollen lymph node and IgG4-enriched lymphadenopathy, how can you tell if it's the Castleman-like presentation of IgG4-related disease or it's Castleman disease with elevated IgG4, both of which are real entities? Well, that's not up to the pathologist. That's up to the clinician. The clinician has to decide, does this fit more with IgG4? Is this patient presenting with autoimmune pancreatitis and retroperitoneal fibrosis and a low CRP? Or is this patient presenting with severe inflammation and high CRP and really just lymphadenopathy on CT scan? So the former would be IgG4-related disease, the latter would be Castleman. So clinical pathologic correlation is crucial. In terms of the figure I provided, these are just some of the examples and some of the key terms that I look for in a pathology report to ask myself, should I ask my Castleman's expert pathologist to look at this? So things like plasmacytosis, so increased plasma cells that are polyclonal, or in panel B, prominent follicular dendritic cells, or in panel C, increased IgG4 positive plasma cells, which we can see in lots of different conditions, EGPA, IgG4 related disease, Castleman disease, atrophic germinal centers. So if you get a viral illness, you will see regressed germinal centers in the lymph node, for example, in someone who's recovering from EBV mononucleosis. But if you see lots of germinal centers with other features, maybe it's Castleman disease, or prominent vascularity, including vessels penetrating the germinal center, which is called a lollipop lesion, or onion skinning. So if I see those sort of key words showing up in a pathology report, I may ask my Castleman's expert to take a look and say, hey, do you think there's enough here to say that it's consistent with Castleman disease?
That's a very helpful tip, and I am sure many of our practicing rheumatologists are very thankful for you sharing that. So you talked about the overlap with IgG4, which I think is fascinating and makes me kind of worry how many cases have I actually missed. But do you ever find Castleman's disease in association with other autoimmune diseases?
That's a great question. The key differentiator between IgG4 related disease and Castleman's is that IgG4 related disease rarely presents with a very persistently elevated C-reactive protein, more than 20 or 30 milligrams per liter, or more than 2 or 3 milligram per deciliter in American units. So that's a key tell. Like sometimes if they got active aortitis, they can have a high CRP. But if someone's showing up with a CRP that's persistently 60, 70, 100 milligrams per liter, that smells a lot more like Castleman's or other autoinflammatory conditions like Stills or EGPA, which can cause a very high IgG4 level as well, than IgG4 related disease per se. So that's one of the things that helps you with IgG4 related disease. Your CRP is your friend, and it's usually low or minimally elevated in IgG4 related disease. In terms of other autoimmune diseases, if you look at the 2017 criteria for Castleman diagnosis of IMCD that David and other colleagues wrote, one of the exclusion criteria for Castleman's is autoimmune disease or other malignancy. And I think the key takeaway there is that if something like lupus or something like Sjogren's is a better explanation for all the patient's problems, then diagnose them with the lupus or the Sjogren's rather than Castleman's, because you can see Castleman-like changes as reactive changes in lymph nodes in anyone with inflammation, really, post-viral, autoimmune disease, malignancy. But I don't think we should say that patients cannot have both. It is possible to have two rare conditions. And we do know that Sjogren's autoantibodies are enriched in people with TAFRO. So there's obviously some overlap in the pathophysiology there. So while it's quite rare to have both, to fully meet criteria for both, I mean, a lot of people with IPL will have some features of Sjogren's, but typically, in my experience, don't fully meet criteria for diagnosis of Sjogren's disease. That's not to say that you could not have both. You're allowed to have two things at once.
So, David, do you have any comment on these patients with small lymph nodes that are hard to biopsy, but yet very sick?
Well, I just totally agree with Luke. These really sick patients, we've got to get to a diagnosis as quickly as possible and get them on treatment as quickly as possible, because they're at significant risk of dying from whatever that is that's causing this sort of a syndrome. We always really recommend trying to get tissue. If you get tissue and it's consistent with Castleman's, you can feel really confident that the TAFRO is due to Castleman's, and you're on your way to helping this patient. I really encourage getting tissue, because I do believe that those patients that are described as TAFRO without lymphadenopathy, I feel that they likely have some other underlying etiology that, rather than us putting the TAFRO label on it, which really describes a syndrome of features that of course can happen in many conditions, that it would be better to keep digging for what is it that's causing that TAFRO syndrome if it's not IMCD and if there aren't enlarged lymph nodes. But I also recognize Luke's important point that these are sick people and they need treatment. And so, we can't spend too long trying to get a diagnosis before we start helping these people.
And then talking about autoimmune disease overlap with Castleman's, I'm interested to know your thoughts too, David. Is there a sense that one diagnosis kind of supersedes the other? So when you see overlapping features of, say, a patient with lupus-like syndrome overlapping with Castleman's, is your sense that the Castleman's takes priority?
Yeah, so I think that when you do have a patient with what looks like a clear rheumatologic condition, let's say lupus, and you do a lymph node biopsy, and that biopsy looks like Castleman disease, I have a hard time considering them having lupus and Castleman. And the reason being that the features of their lupus easily meet the diagnostic criteria for IMCD, and having a lymph node that looks like IMCD to me is not enough. So I'm more in the camp of, if you can explain a diagnosis with a common autoimmune condition, or even a more rare autoimmune condition, but a more clearly defined autoimmune condition than IMCD, then I'm of the mind that you should label that patient with that diagnosis, and you should begin trying to treat them for lupus or for RA. Now, if those patients are non-responsive and you see major challenges that you wouldn't expect from your other patients with SLE or RA, that's when I think it's probably worthwhile to revisit. Could this actually be IMCD? The patients with IMCD and lupus that I feel confident saying, yes, I think they have both, are the patients where they have a separation in time between their initial presentation, let's say, of lupus, and it presented one way, and then there's a new presentation that happens some amount of years later, and it just looks very different. It doesn't look like their lupus presentation. It now looks like a different thing. Usually it ends up being a TAFR-like presentation. And those people, I feel comfortable giving both labels. But in general, just because IMCD is so nonspecific, because the lymph node features can be found in so many conditions, and there are nonspecific lymph node features, if there's another immunological diagnosis that can be made, I'm generally in favor of giving it the other diagnosis. And of course, this comes from someone who has IMCD and who studies IMCD. So of course, I love the condition. I want it to be diagnosed in everyone who has it. I just also see the tremendous overlap. And I've spent so much time looking at lymph nodes from people with lupus and RA and so many autoimmune conditions, and there's just see the overlap, which makes me hesitant to give someone both titles.
You are giving us so many incredible tips for clinical practice on this podcast today. Let's talk a little bit about treatment. And this is something that's undergone really significant changes in the last few years. David, when you were diagnosed, there was only one option for treatment and it didn't work for you. You then dedicated your life to finding new treatments and understanding the pathways involved in this disease. Tell us about the current guidelines and what options are now available for treatment.
Sure. So we came out with guidelines back in 2017. And so every single IMCD patient, we recommend treating them first line with IL-6 blockade with siltuximab if it's available, or with tocilizumab if siltuximab is not available. That means no matter how sick the patient is, we recommend starting with IL-6 blockade. Now, if that patient is very sick and very severe, we consider them to fall in the severe category. We recommend that they give that patient corticosteroids along with the siltuximab and begin dosing at an accelerated rate. So every week instead of every 3 weeks. And we recommend daily or every 2 days laboratory values so that way you can get a sense for how is that patient doing. And if the patient gets worse while they're on IL-6 blockade, while they're getting laboratory values measured every couple of days, then we recommend adding on combination chemotherapy to try to get the disease under control. The reason for that being is that these severe patients are at significant risk of death if you don't aggressively control the disease. Now, for patients that don't meet the severe criteria, we recommend starting IL-6 blockade just like the severe patients, but doing it at every 3-week dosing, which is what's on the label for siltuximab, not needing corticosteroids along with it, and having the luxury of time to follow that patient for, let's say, 3 or 4 cycles, so 9 to 12 weeks, to see how that patient does. And if that patient progresses and or if they become severe, you need to treat them like they're severe. Or if they're progressing rapidly, you need to think about second-line therapy. But really, we recommend IL-6 blockade up front for everyone. And then the big question is, do you give them aggressive chemotherapy if they're progressing? Or if they're more mild, moderate, then you can try other second and third-line therapies like sirolimus, like rituximab, like thalidomide that can potentially help these patients.
Yeah, incredibly helpful information. And we're so grateful for you for really changing the course of this disease. It's incredible how much progress has been made in such a rare disease in only 15 years. And much of that progress was due in part to the work that you, David, and the community of researchers and fellow patients did coming together to form the Castleman Disease Collaborative Network. Can you tell our listeners about this group and how you collectively galvanize this community to accelerate progress?
Sure. So when I was diagnosed 15 years ago, we didn't have diagnostic criteria or treatment guidelines, poor understanding of how the disease worked outside of IL-6 blockade. And we really didn't have a community. We had a bunch of amazing doctors and researchers all over the world that were spread out, but there was no community to bring us together. And so we brought together first a group of patients from around the world, then physicians, then researchers, loved ones of patients, all together through virtual forums online, but also through in-person meetings. We've been doing this for about 15 years now. We actually have a patient summit coming up in a week's time where we get together over 150 patients and loved ones from around the world into Philadelphia. So we got the community together, and then we immediately prioritized, we got to come up with the diagnostic criteria, come up with treatment guidelines. We got to better understand how this disease works, what additional treatment approaches can be taken. And it really was this very patient-centric approach where patients were actually involved in helping to prioritize what research should be done. And we found it just to be transformational.
And our listeners may not fully appreciate this for hearing from you now, but at the time you were diagnosed, you were really very sick. Indeed, in your book, you talk about a priest giving you last rites. Looking back, what do you wish you'd known when you were sick, both as a patient and also what do you wish your physicians had known?
Yeah, it's a great question. I mean, I really wish that my physicians knew then what we know now about IMCD, and that's that patients can present very severely like I did. My doctors were concerned that maybe I had a severe infection or an aggressive lymphoma. My rheumatologist came in and evaluated a lot of more common autoimmune diseases, but didn't consider IMCD, or actually one of them did, but because I had just mildly elevated interleukin 6 levels, they ruled it out, and IL-6 levels can't be used to rule out IMCD. And so I definitely wish that they knew now knew then what we know now about the disease, even just awareness that they should be thinking about it. And then certainly I wish they had guidelines to make the diagnosis. For me personally, it's sort of hard to even believe that I'm alive 15 years later and that I ended up surviving a total of 5 of these deadly flares. So I guess I would just tell myself, like, just keep fighting. You're not going to believe it, but 15 years from now, you're going to be on a podcast with Luke Chen, and you guys are going to be talking about rheumatology and all the things that you guys have been able to accomplish over these last 15 years. So just keep fighting.
Amazing. And as a physician scientist now, you lead a nonprofit organization called Every Cure, which focuses on mining large data sets to identify potential targets for drug repurposing. Tell us about this work and where have you had successes?
Sure. So this is very much inspired by what we did for Castleman's. I mean, I'm alive thanks to sirolimus, which was not made for Castleman disease. It's used for organ transplant rejection, and it saved my life. And, ever since that moment, which is about 11 and a half years ago, I can't stop thinking about how many more drugs are out there that could be repurposed for new uses. And so we've gone on to do this with JAK inhibition in Castleman's, more recently, along with Luke, TNF inhibition, and finding new uses for medicine. So 3 years ago, launched this nonprofit, Every Cure, to really scale this approach where we utilize artificial intelligence to look across the world's knowledge to find the most promising repurposing opportunities to then perform further laboratory work, clinical trials, and to get them to patients. So really AI-powered drug repurposing, but end-to-end to make sure that the things that look promising, we actually get to the patients who can benefit.
So, Luke, you are a hematologist. How did you come to know David, and what made you want to work together on this manuscript?
That's a great question. I mean, first, I feel very fortunate to be able to work with David and Every Cure. We had a lot of overlapping interests many years ago. David had reached out to me to see if I had HLH biobank samples so he could compare them with Tafro. And unfortunately, at the time, I did not. But he and I sort of crossed paths in that I reviewed some of his papers and he reviewed some of mine. I'll make a point that David mentioned that IL-6 levels are not always very elevated in Castleman's. And I think that's a key point. Although IL-6 drives the disease, many people don't appreciate that in the serum, IL-6 is a buffered system. So it has to be received by the soluble IL-6 receptor, and the whole system is inhibited by SGP-130. And so even in diseases that are clearly driven by IL-6, like rheumatoid arthritis, Castleman's, severe COVID, giant cell arteritis, and that respond to IL-6 inhibitors, the IL-6 levels are often not very high in the serum. They may only be 20 to 100 picogram per mil, whereas in other syndromes like sepsis or ARDS, they can be very, very elevated, several thousand. And in those conditions, IL-6 inhibition is not necessarily helpful. So I think it's an important thing to keep in mind that actually, as a clinician, the C-reactive protein is a much better friend than trying to send out IL-6 levels on a patient where you suspect they have Castleman's. If the CRP is very high, then IL-6 is acting in the body. And so David and I sort of had these indirect communications or reviewing each other's papers for a while because our research interests were overlapping. But then in 2020, I had a patient who became very sick with what we initially thought was an atypical presentation of COVID and then maybe HLH. He had severe inflammation and anasarca and low platelets, and he had small lymph nodes, and ultimately we got a lymph node biopsy done and it looked like Castleman disease. And so he had very severe IMCD Tafro, and I wasn't sure what to do with him. So I emailed David and I asked for advice. And that night he called me back at, I think I was in Vancouver at the time. So he called me at what must have been 9:30 or 10 o'clock Philadelphia time. And he walked me through the case and gave me advice. And so ever since that time, David and I have collaborated on a number of things. Really, I'm just trying to add on to CDCN and Evercure what I can as a clinician. And then that patient actually had a very refractory course, and he had failed multiple therapies. And each time he was failing a therapy, I'd spoken to David and he'd given me advice, and we tried something and it would work, and it would work for 6 months or 7 months, and it would stop working. And by January of 2023, we thought we had run out of options. This patient, he was only not even 50 yet at the time, and had been previously very healthy before he got Tafro, but he had gone through so many therapies, including chemotherapy, including an autologous stem cell transplant, and kept blowing through it. And I thought we were out of options. I had actually consulted palliative care. He was getting ready to go to hospice. And I called David one last time for advice. And David said, in his lab, the wet lab was showing that tumor necrosis factor, TNF, was an underappreciated culprit in Tafro that is probably doing more in Tafro than we previously realized. At the beginning of the podcast, we talked about the central role of IL-6, but we also talked about the fact that it can't just be IL-6, because only about at most half of people have a really good response to IL-6. So there must be other cytokine and inflammatory pathways involved. And so the wet lab, through RNA sequencing and proteomics, found that DNF was probably a culprit. And then the dry lab, the machine learning lab, which is what has become what we know today as Evercure, when they ran it through their algorithm, they predicted, out of the top 10 predicted treatments for Castleman disease, 2 of them were TNF inhibitors. And most of the others were things that we already knew about, things like steroids and chemotherapy and IL-6 blockers. So the TNF inhibitors were a surprise on that list from the AI algorithm. And so David told me, you know what, the wet lab's saying TNF is a culprit. The dry lab is saying TNF inhibitors might be a solution. Why don't we try it? And I was a little bit skeptical because, to me, TNF inhibitors, they're useful for people with sore, swollen joints. I don't know if it's going to help this person with severe inflammation and end organ failure. But we tried it. And amazingly, a few weeks later, when he came to my office, he was in complete remission. And so we wrote that up, and it was published in the New England Journal of Medicine exactly 2 years later, on the 2-year anniversary of his remission. And so, it's just been amazing to be able to contribute in a small way to the work that CDCN and Evercure are doing. And so when David and I were talking at the last American Society of Hematology meeting, he said, Arthritis and Rheumatology has asked me to write a review. Would you help me with it? And I said, I would love to do that. So that's how we ended up with this review. And it's just been fantastic to work with David and Evercure and to see the progress that we can make.
Oh my goodness. We're so lucky that you came together and wrote this manuscript, and that we've had the chance to hear from you today on this podcast. I truly do think you are an honorary rheumatologist.
Oh, well, thank you. And, I just want to close out by acknowledging our colleague Lu Zhang, who was also a co-author with us on this. When we say something is rare in the West, it's not always rare in the East. So Lu works in the most prestigious university in Beijing, PUMC, and he has hundreds of Castleman disease patients. So it's really been a pleasure to work with David and with Lu and to learn from both of them.
That's brilliant. I am so grateful to both of you for coming on the show today and for writing this manuscript, which I think will be a classic for people from all specialties wanting to learn about Castleman's disease.
Well, we so appreciate you and so appreciate the opportunity through your journal to get this information out to rheumatologists all over the US and all over the world. If you're listening to your rheumatologist and you ever think of HLH or you ever think someone might have lupus, please think, do they actually have IMCD?
Wonderful. Thank you.
Thank you so much, Vicky and David.
Thanks so much, Luke.
A big thank you today also goes to people living with these complex autoimmune diseases. What David's story shows is that we can make more progress together than any of us can make alone, and collaboration across boundaries can accelerate discovery. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRheum on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.